It's really great to be here. What a blessing. What an amazing conference and some wonderful speakers. You know, it's so uplifting to hear from Dr. Young and Dr. Putoff, and it's like a big reunion. And then for me, it's actually it hits close to home. I was born 4 miles from here. St. Mary's Hospital does it still exist? I don't know, but it did in 1976. And so I'm the second oldest of 5 children to Dr. Tom and Sue Hilgers, and so obviously I've had a kind of a front row seat to all that we've talked about today, or a large part of what we talked about today, which has just been really a blessing for me just to see that growing up and being able to see that firsthand. It's so neat. And Diane Daly here, who's so special to us and our family, and really such an important person, just foundationally for what has been done all these years. And so it's you. And then my dad last night getting the award was really special for him and for our family. So John, thank you for the invitation, and Patrick, thank you for the invitation. And so I'm going to piggyback a little bit. We've heard a lot about the medical applications, and so I'll skip over some of this. It's only 125 slides long, so sorry. This is kind of like my life biography here in a way, just what I grew up with, so I apologize. It's hard to limit when you love everything, right? But I am at Houston and not in Omaha at the Institute, which I know is probably kind of hard to imagine, but I say there's only 2 things that bring people to Houston, Texas. One of them, the Holy Spirit, of course, and then the second is marrying a Houstonian. My wife is from Houston, and so I guess I did both in a way. So I'm down there in the Texas Medical Center. We're growing NAPRO there and the Creighton Model and Fertility Care System, and we have so many stories, just like all the other wonderful doctors who have spoken today and really shared a lot of what they've seen and what their patients have experienced and the positive benefit and growth. And so this is a Humanae Vitae conference. And that is, of course, such an important document. I think I read that in my family before I even learned the ABCs. I think it was, here's the Humanae Vitae, and it's like, what is this? And so in a way, I hadn't read it in about 30-something plus years, but so to come and speak on this, to me, is really just such a wonderful gift to be able to do that. And of course, that comes from the church. And so in essence, what we're talking about today, everything comes from the church, which is really amazing if you take a step back and think about it. All of the science, all of the surgical applications, from everything Dr. Young is doing, endometriosis care, and what Dr. Putoff is doing in infertility, and so on and so forth, it really comes from the teachings of the church. And that's so foundational. And so I just want to take a step back and in a way see what Humanae Vitae and the church has done to not just impact the patients and the doctors and the healthcare workers and the practitioners and all the people in this area, but really what it's done for women's healthcare, which is really huge if you think about it, and couples in that area. So I will gloss over some things, and I better get started because I only have 45 minutes. And in fact, my parents met at the University of Minnesota, and the reason they met, this is kind of a funny story, is my dad, who was supposed to speak for an hour, spoke for 3. And my mom, who was running the thing, Sue Hilgers, went up and said, listen, I don't know who you are, but you just blew through our whole afternoon. And so I guess it runs in the family to be a little long-winded. So I have no relevant financial disclosures. The cultural shift in women's healthcare. There it is. It started back in 1957 when we had the birth control pill, and it started out with good intention. Women had some irregular cycles, and the idea was, here's some medicine that might help with that. In 1959, women were using it not just for the cycle irregularity, but also for its positive side effect, which was the family planning side of things. Since that time, the legalization of the birth control pill, you can see here, it's just taken off, really exponentially in terms of the amount of women using it or couples using it. I shouldn't just speak to women because this is a couple-centered idea too in terms of family planning, but 100 million in 2013, which is really quite amazing. As you know, the Catholic Church stands alone Period, end of story. 1930s or prior to that, everybody was on the same page for the most part. Contraception was not moral, it was not encouraged, and it was condemned. As you all know from reading in 1930 and then it followed up in 1958, in the Anglican Church and the Lambeth Conference decided that we would make some exceptions for contraception, and the remaining Protestant churches shortly thereafter followed suit. So what that left was the Catholic Church alone, standing on the idea that contraception goes against the grain, the moral grain, and it is something that should be condemned. So today, the Catholic Church alone proclaims the historic Christian position on contraception, which is really remarkable if you think about it, as it trickles down to what we're talking about today, which is women's health and the applications there. So when I think about the church and what it has to offer, it has so much wisdom to offer us. I think of Humanae Vitae, of course, this wonderful conference. And then love and responsibility. I think somebody mentioned love and responsibility earlier today. I'm a graduate of the Pope Paul VI Institute Fellowship Program, St. John Paul the Great. And as part of our core curriculum, as doctors, we actually take an ethics class where we read Humanae Vitae and we read love and responsibility. As physicians, that's really important as you get into this area. It's foundational. As most of you know, we've already talked about Humanae Vitae, but St. John Paul the Great in Theology of the Body, which was a series of lectures that he gave audiences at St. Peter's Basilica from 79 to 84. They've been published. And then Love and Responsibility, published around 1960, prior to becoming Pope. So when he was in Poland. John did a wonderful discussion this morning on Humanae Vitae, but as we know, it outlaws birth control, right? And there's a lot of wisdom there for that. And sterilization. And importantly, Pope Paul VI says it excludes any action which either before, at the moment of, or after sexual intercourse is specifically intended to prevent procreation. Now, shifting gears to love and responsibility, and John Paul II, St. John Paul the Great, he elaborates on this. God is creator. God is creator. I think we all believe that. We all understand that. We all know that in our heart. And within the vocation of marriage, he says, God allows man and women to co-create with God. That's a remarkable thought. It really kind of blows my mind. I can't create anything. Nothing long-lasting, that's for sure. But God says, husband and wife, man and woman, you are now allowed to enter with me, and I want to create with you human life. And we've lost that concept. And that's a great and really amazing blessing that God gives us. For God to say, I'm going to create with you is remarkable. And we kind of lose that in a way. And JP2 talks about, says marriage is monogamous and it's a durable institution which justifies the sexual act in its primary purpose, which is procreation. Protecting that idea of allowing us to come and be one as a couple with God to create new life. Openness to life within the sexual act eliminates reciprocal egoism, objectification of the spouse, either way. Exploitation. Honors God, pays justice to God, the Creator. And it results in true love of marriage. And then he says, finally, human love loses nothing with periodic abstinence. In fact, the personal union becomes affirmed more deeply. And as you affirm the other's value. And in terms of understanding the natural methods, which has been such a theme today, he goes on to say, understanding natural methods of fertility challenges us to respect the bodies of our spouses, encourages tenderness, favors education and authentic freedom, and allows us to appreciate the innate language between husband and wife. And he goes on to say that contraception is objectively contradictory to that language. It's building a barrier, right? I kind of want you as my spouse, all of you, but really not all of you. And I think most of the people in this room have heard that idea expressed. It's a positive refusal. Not interested in reproduction with you right now. And whether we like it or not, or whether or not we, really comprehend that in our relationships, it's there. And I think in some relationships more than others, but it's there. It may be subtle, maybe not so subtle. And it's a falsification of love, or true love. Humanae Vitae called the men of science, including doctors and medical professionals, to provide a secure basis for the regulation of birth, founded on the observation of the natural body and the natural rhythms, and obtain the knowledge needed to help couples in this area. The Pope knew that we didn't have a lot here, and we needed more. Birth control was coming out. It's very easy, very effective, so on and so forth. And I think the Pope realized that, we need to put some efforts here, and that's where the call came from. So let's talk about women's health now. So that's what the church has to say about women's health. Has a lot more than that to say, but that's kind of it in a nutshell in terms of JP2 and Humanae Vitae and the impacts there. But things have changed greatly in how we treat women and how we treat couples in medicine. Nowadays, the birth control pill is used almost universally to treat disease processes. It has become the first line, both socially and medically. Just open the paper and read. Politicians say the birth control pill is not a family planning tool, but it's essential health care. In our country, and I think around the world, it's accepted as that way. In the OBGYN office, it is the baby aspirin. It treats everything. It's given in that way. And we're going to look at some of those. What's resulted is a direct mirror image of what the church warned against. Contraception and the headlong dive into using it for just about everything has resulted in women's health care that is contradictory to the female reproductive system. It leads to a positive refusal of the natural female reproductive gynecologic organs and state. And it's also a falsification of true health, which is something a lot of women don't understand. They're given the birth control pill for PMS or irregular cycles, or as Dr. Young so expertly explained to us for endometriosis, I can't tell you the number of patients who come in and say, well, I need the birth control pill because it's treating my endometriosis. It's treating your endometriosis as much as Tylenol or Motrin is. It's helping with the symptoms, but it's not treating it or curing the process. So it falsifies health care for women. So let's look now at what the church has said. Again, the Catholic Church is it. Unfortunately, the other churches, they haven't made any statements on this. I showed you that slide. Without the Catholic Church's stance on this, we have really nothing in this area. So what has resulted? And so, having grown up at the Pope Paul VI Institute, now a NAPRO fellow and a full-time practicing NAPRO physician in Houston, certainly we've talked about other fertility awareness methods, but I do want to highlight Humanae Vitae and the call and what has resulted. a direct result of what Diane and Ann Preble and Sue Hilgers and Tom Hilgers and now people all over the world is a result of the call in Humanae Vitae. That has resulted in the Pope Paul VI Institute. I remember the groundbreaking in now I can't remember, 80-something. Medical and surgical naprotechnology, which are the gynecologic sciences that have come from the Institute and the fertility care charting system. And now, most recently, the St. John Paul the Great Society of Procreative Surgeons. The fertility care system, we've talked a lot about fertility awareness systems. But going way back to St. Louis in the 70s, the idea is we need to have a reproducible, objective system that couples can use that works for them. Getting away from the things that don't, but something that works. Couples need a natural method that they can rely on to plan their family. Out of that came the Creighton model and what's now known as the fertility care system. As you all know, it's a fertility-based method. I'm not going to go through all this because I think we've pretty much beat that horse, so to speak, I guess. It's objective. So those of you who aren't too familiar with it, it's objective. So all of the biomarkers are objective. They're not standardized in any fashion. The teaching schedule is standardized, so couples learn on the same schedule as a couple in Brazil or a couple in Antarctica. I think my dad said last night we don't have anybody in Antarctica. It's the only country we don't have, so we're shooting for it. But we now have standardized, fully accredited teaching programs for nurse practitioners, medical consultants, fellows in obstetrics and gynecology. Dr. Putoff is a graduate of, and I think we have some other fellows here today too. And then of course national, international accreditation, which is so important, both here in the United States and abroad. The fertility cycle in gynecology has been ignored. Why, I don't know. It's like going into the office and saying, I have low thyroid. Well, I'm not interested in your thyroid. That doesn't make any sense. You evaluate the thyroid, right? But for some women, for some reason in women's health, we've completely given up on looking at the menstrual cycle. That doesn't make any sense to me at all as a doctor. It shouldn't make any sense to anybody who's not. But it's been ignored in both practical and scientific application, largely by the community. Through the Pope Paul VI Institute and through the careful evaluation of these charts, certain medical treatments started to arise. It's so neat. I still remember my dad saying, after I looked at my 10,000th chart, I started to realize there were some similarities and dysfunction that was going on. It makes sense. If you start looking at something, you're going to start seeing issues and dysfunction and things that need to be treated and changed. And when you're looking at an area in women's health that's totally ignored but is essential to their reproductive health, you're opening a huge box to help folks. You really are. You're entering a world where you can really make such an impact. And that started at the Pope Paul VI Institute with the Creighton model and the fertility care system, and then led to, as we were looking at these charts and researching them and seeing all these different similarities between women who had low progesterone and recurrent miscarriage, endometriosis, and on and on and on, the research started from there. And it's resulted in great and significant advances. There are so many that need to be done yet, and that'll go on as long as we're alive and the next generation is alive and so on and so forth. But it's been shown to be medically safe, reliable, standardized, inexpensive. So there's so many wonderful pluses from it. And it respects the dignity of women, marriage, and the reproductive cycle. This is the textbook. It was published in 2004. This is a picture of my dad presenting the textbook to Pope John Paul II. Because of the church's call and the response within the church, women's health care has been transformed. And I mean that. Women's health care nowadays is not health care, unfortunately. And a lot of the doctors talking today are so excited to share it with you because it's really just basic women's health care or basic gynecology. Let's look for the problem, let's try to figure out what's going on, and let's treat it. And then you start to get some really neat results from that. So I just picked a couple things. You could pick 10 or 20, but I thought I'd pick a couple that are really important for those who don't understand NAPRO or aren't exposed to it or don't really understand the medical applications and are trying to figure out, well, where does this fit and where can I be a benefit to patients and maybe where in my hospital system would this fit and how would they be different than what's going on. Let's talk about family planning. Why does it matter? I think we all know why it matters. All couples should be able to plan their family safely and effectively. An effective family planning system in the truest sense is one that allows couples to avoid and achieve. I went through medical school. I grew up, with NAPRO technology and fertility care, and I still felt brainwashed when I went through medical school because everything with family planning was avoid, but nothing about achieving. But a true family planning system does both. It's not fair to couples to say, can I help you with family planning? Well, that'd be great. Could you help me? Sure, of course we can, but we can help you avoid. Can you help me achieve? No. We have no earthly clue how to do that. Believe it or not, I have patients who have seen gynecologists who come to me, and I think somebody touched on it. I don't remember which one it was. I think it was Dr. Young's slide where he showed just teaching basic things like the fertile window, and you start to see pregnancies, and you wonder why medical school education is as expensive as it is. I mean, they should be getting discounts for that. That's basic. I mean, that's very basic, but for some reason we've totally wholesale missed it. Mainstream treatment strategies, as you all know, condoms, IUDs, you name it, the patches, injections, designed to avoid. That's it. I don't know of a condom that helped any couple achieve pregnancy, unless it, I guess, maybe if it failed, but you know what I mean. They are not true family planning systems, and so we need to stop talking about them as such. The language in our country changes things. We say these are family planning. They're not. They're pregnancy avoidance systems. The church's response from Humanae Vitae has led to systems that are true family planning systems. True family planning systems. This summarizes a lot of the data you've already seen today in terms of the effectiveness with the fertility care system. And Dr. Stanford is working on the new set of data there for effectiveness. So what you see here is the effectiveness of the Creighton model fertility care system, both achieving and avoiding pregnancy. And when you talk to couples about planning their family, this is really what they care about, They want to know that they can use something to achieve and avoid, and they're not left to their own devices to try to figure out when is their fertile window and how to do that. Studies have shown that when the fertile window is used accurately and consistently, the time to pregnancy is increased significantly. Decreased significantly. The time is decreased. We saw this in an earlier lecture. This is the fertile window. Couples left to their own devices. This comes from the major reproductive endocrinology textbook. 3 months, 57% pregnant. In a year, 85% pregnant. Using a system that allows couples outside of the doctor's office, on their own, at home, in the privacy of their home, to know when they're fertile, to use those days. 1 month, 76%, and 7 months, 100%. I mean, that's remarkable. Just that little bit of education speeds it up. Wonderful study came out in the Green Journal, which is one of the big OBGYN journals, and they looked at different ways to identify the fertile window. and I think it's on this, 53 smartphone apps, the top 53 they looked at to see, this is echoing what we talked about in the morning, but they're generally inaccurate, with only 3 apps out of 53 correctly identifying the fertile window. That tells you something. We have no earthly clue where the fertile window is, how it gets there, where it should be, and that's actually pretty embarrassing. Those are the top ones, and you know, women come to my office every day, and the first thing I ask them is, well, how are you trying to? Well, they say, you know, we're having trouble achieving, and the first question I ask them is, I say, well, how are y'all trying? And inevitably, one of them chuckles and says, well, this guy's a fertility expert? What do you mean, how are we trying? How are you trying? You know, and I said, well, no, how are you identifying your fertile window? And then they're usually, well, we've got this app, you know, we got on just like everybody does. Steve Jobs did a lot before he died. One thing he did not do is develop a fertility app that works, okay? There are a lot of calculators too. There's urine LH sticks, and there are some issues with those, and women with long and irregular cycles and PCOS. You'll have patients come in that are doing those. At least that's a good first start. But inevitably, they can have frustration if they have PCOS or long cycles, irregular cycles. And the American Society of Reproductive Medicine, which is the big group the big Society for Reproductive Endocrinology and Fertility in our country, they have a wonderful practice bulletin on natural fertility, which I think is really interesting because the first sentence says, and this is geared towards reproductive experts, doctors, and they say, every once in a while you might get a couple that comes in and says, we'd like to achieve on our own. What is that? It was interesting. And you might need to give them advice about how to do that. We talked about the propensity for IVF and things like that. And in that article, they said a fertility awareness system is equal to, if not the best way to do that. And they talked about the different pros and cons of the different things you can do. So the church's response has resulted in a complete family planning system that's safe, effective, in allowing couples to avoid and achieve. Modern methods are simply pregnancy avoidance, and the few things that are on the market are fraught with inaccuracies and can be very difficult and frustrating for couples who have irregular cycles. What about PMS? Have you all heard about PMS, premenstrual syndrome? It's a big one. It's a big issue. Why does it matter? We've talked a lot about infertility today. I'm going to talk about other gynecologic applications because, believe it or not, these NAPRO technology involves not just infertility, but a lot of areas too, and one of those is PMS. So it's a cyclical occurrence of symptoms that occur within a certain segment of the woman's cycle. 75% of women experience some recurrent symptoms. 20 to 40% are mentally or physically incapacitated to some degree. 5% experience severe distress. Highest incidence occurs when women are younger, about 20 to 30 years old. Moderate to severe can result in decrease in work productivity. And then there's premenstrual dysphoric disorder, which has resulted in, has a higher risk of suicidal ideation and suicidal attempts. Mainstream treatment strategies are designed towards treating depression. So antidepressants are usually the first line, or anti-anxiety medicines. If that doesn't work, then a suppressive therapy is given, like the birth control pill, to completely shut down the cycle. And the mainline one is a drospirenone birth control pill. If that doesn't work, then women are put on a medicine called a GnRH agonist, which places that patient into a medical menopause. So here we're talking about a young woman, 20 or 30 years old, taking a medicine that puts them into menopause. Very difficult to be on, and requires add-back treatment on top of it to prevent bone loss and those types of things that are dangerous to be on long term. If that doesn't work, then surgical removal of the ovaries. So we're just removing the ovaries altogether. Interestingly enough, the main birth control that is used for PMS is still prescribed today, is involved in 12,000 lawsuits right now for blood clots that are known to develop with this medicine. Yet young women are still put on it. And you got to think to yourself, now why is that? That doesn't make any sense at all, really. The way that's justified in gynecology is the following. Well, that patient isn't pregnant, and the risk of a blood clot in pregnancy is higher, and so therefore will justify this slight increased risk in blood clots in order to treat PMS, because then they're not getting pregnant. So it's still on the market, it's still prescribed. 12,000 lawsuits. I mean, that's just unbelievable to me. Why not something else? The natural reproductive system has been ignored, and the study designs on ones that have looked at things like natural progesterone and estrogen support have not been done according to when a woman ovulates or appropriately timed during the cycle. The church's response. This I call the Monet. So this should be hanging up in some sort of a museum somewhere. I probably show this to my patients at least 10 times in a day, but this correlates the cervical mucus discharge, the fertility care system, relation to ovulation, and the hormone patterns. And as you can see, you can't check a hormone level on Monday and check it on a Wednesday and expect it to be the same. So female hormones fluctuate throughout the month. So you have to know when you're drawing and when you're evaluating things to accurately diagnose and treat disease. This is an example, really a classic example that we show at our EPs. This patient really wanted to know if she was ovulating, so the doctor drew a day 22 progesterone. And you can see on the chart that that was way before ovulation even occurred. So she was told that she was anovulatory. The problem is she hadn't ovulated yet. And so you're drawing at the wrong time and you're making the wrong conclusions. Using the fertility care system and medical nanotechnology, we can have the patients come in at the right time during their cycle, have their blood drawn. That's what these little red marks are. We can evaluate progesterone in a time fashion and estrogen, and we can treat those. And you can have significant improvement in how that woman is feeling. And that's in conjunction with her natural cycle. Makes sense. If I have a low thyroid, the doctor's going to put me on thyroid medicine. Now take that example and say, well, you have a low thyroid, days 12 through 18 in the month. Take the medicine then. You're probably going to feel better during those 6 days. But for some reason, when it comes to women's health, I don't know if it's just, we don't want to do it. But it's not all that hard to do to evaluate hormones in a timed fashion and then have patients treat it when they have the deficiency. And believe it or not, they start to feel better. So this is just showing you the antidepressants, which are about 43% improvement. But with progesterone support time during the cycle, you can get to 78%. And with HCG support, which allows the body to produce both natural estrogen and progesterone, almost 85% improvement. I want to go quickly through a case example. This is a patient who came in. She was 43 years old. She had the following symptoms. You can read through those. Severe PMS. 7 to 10 days before her cycle, she felt like she crashed. And she just came in and said, Dr. Hilgers, I'm tired of being on the birth control pill, or people tell me to be on a pill or antidepressant. So we evaluated her hormones, and you can see about 7 to 10 days before her cycle ends, her progesterone level crashes, as does her estrogen. Exactly what she was telling us in the office. In fact, it's really rewarding when you ask a patient when their symptoms start, evaluate their hormones, and then put the two together, because they almost match perfectly. So she was treated, not with birth control pill to suppress, just timed natural progesterone when she needs it and estrogen, marked improvement in her symptoms, and she still feels good today. So the church's response to women's health has resulted in the ability scientifically, the scientific ability to accurately evaluate hormones, the ability to diagnose dysfunction, and the ability to treat it. Mainstream treatments are designed to suppress or surgically remove the ovaries. PCOS, irregular cycles. This is a major issue in gynecology and gynecologic health, especially for young women and who have irregular cycles, or young women experiencing fertility, couples experiencing fertility. PCOS, the hallmark is irregular cycles and ovulation in an elevated androgenic state. Gynecologists are taught that the birth control pill is really the main treatment for this. There are a whole host of issues that go hand in hand with PCOS that affect women, from elevated risk of diabetes to infertility risk to endometriosis to abnormal bleeding, elevated lipid levels, ovulatory dysfunction. Depression and anxiety is a lot higher in these patients. Ovulation tends to be dysfunctional, and then the hormones associated with ovulation tend to be dysfunctional. Mainstream treatment strategy, at this point you probably guess what the treatment is. It's really birth control to suppress everything. And so it's usually done in a way where a woman has a placebo period. So they're given hormones, ovulation is suppressed. They have a withdrawal bleed from the medicine. And the unfortunate thing is women are taught that this is a treatment, and that gets back to that falsification idea that JP2 talked about. What happens is they go through their early years on it, and then they get married and get off of it, and it's time to start a family, and that issue's still there, and it's never been treated. And in a way, they've been kind of sold a bill of goods by gynecologists telling them it's being treated, but it's not. The church's response, treatment strategies. This is a polycystic ovarian syndrome chart. As a NAPRO doctor, when these patients come in, it's remarkable. You can spot it immediately. You see all these white babies through there. This is what I call the I think I can. And so you remember that childhood book of the train trying to get up the hill? I think I can, I think I can. So I always tell patients this. Very simple in my examples. It's the only way I can remember them. But it's that ovaries trying to ovulate. And so it's that I think I can. And as you know, estrogen surges as that body tries to get that egg to be released. And with that, you get cervical mucus. And so you can see all the I think I cans. Until one of two things happen. Either the woman has a bleed because she doesn't ovulate, or finally the train gets up and over the hill and the ovulation occurs. And you can see that pretty clearly on the chart, which ones are going on, if they're completely anovulatory or they just have an ovulatory dysfunction. And Dr. Putoff talked about stimulation medicines and Clomid and Letrozole. And why do we use those as Catholic physicians? Of course we do. There is ovulatory dysfunction that exists. And women do need help in that area, and we have wonderful treatments to help them with that. Taking progesterone in a timed fashion, along with NAPRO treatment protocols that involve natural ovarian support, you can start to regulate these cycles. I like to give case examples. This was a patient who came in. She had PMDD, the worst form of PMS. I remember when this patient came in, she was very disheveled. She had been to a bunch of doctors. She was on multiple psychiatric medicines for all of this. She had long and irregular cycles. We diagnosed her with PCOS, had her start charting her cycles. We were able to gain cycle regularity with just progesterone timed, got her on natural ovarian support, which allowed us to finally get her to ovulate in a regular fashion. And once we were able to do that, we were able to evaluate her hormones. This is her charting with progesterone support. And then you can see it gradually improved to the point where she was having monthly cycles on her own, not with medicine, not falsifying the picture, but on her own. And she can see her body healing. That's really remarkable for folks to see it. It's so empowering. It's so awesome. They see their body healing. Our infertility couples, they see it. They see their cycles. They see their reproductive system healing. This was her estradiol curve. By the way, it's the one, I didn't get I don't have a pointer, but it's the one that doesn't look like the others, okay? So it's the one that's down. And this is her progesterone curve. We were able to get her on natural hormone support in addition to the PCOS treatment protocols. She's now cycling regularly. And I think she's off of almost all of her psychiatric medicines except one. And she told me, she sent me a note, she graduated nursing school and she has a boyfriend for the first time, so she's so excited, which is really cool. So the church's response to women's health has resulted in treatments that are tailor-made for women with irregular cycles, those suffering from PCOS, modern treatment suppressive in nature, right? Falsify the act in a way. Infertility, I'm just going to spend a minute on this because I think Dr. Young and Dr. Putoff did a wonderful job getting into a lot of the NAPRO applications there. I think it becomes, NAPRO and infertility become almost interchangeable because just over the years, we've just dealt with so many couples and been able to be such a big impact there. And there's no doubt that there's wonderful things that are being done there. Why does it matter? We all know why it matters. Infertility has increased in our country significantly since the 80s. There's reasons for that. You can read them here. This again comes from the major reproductive endocrinology textbook. The causes are wide and broad. So there's a lot of them. So if you're going to really look as a physician into the causes, you have to look at everything. From male factor to hormone dysfunction to endometriosis to tubal disease, so on and so forth. Mainstream treatment strategies are listed here. And this is a wonderful slide out of the Institute that was put together by Dr. Tom Hilgers. And it shows mainstream, which is identify, kind of do a cursory evaluation. We talked about the fact that a laparoscopy isn't even done anymore for patients with infertility. Very cursory, some ovulation stimulation medicine. And if that doesn't work, quickly to IUI for 1 or 2 cycles and then IVF. IVF does not help near as many people as you'd like it to. It leaves a lot of couples without treatment and without help. There's also a lot of devastation and wastage that occurs, okay? Number of embryos transferred for 1 cycle, about 3.6. Embryos per live birth, about 6.7 to 1. It's remarkable. And the percent of women helped, 0.47%. I can't tell you the number of couples who come into my office and I say, well, what brings you in? Well, I heard about NAPRO. And they give me a little bit about their history. They've done IVF, or maybe the IVF doctor said, you're too old for IVF. You know, or you've already tried twice, we're not going to do it again. One of the reasons is there's a big push for success rates. And so believe it or not, there's couples who are turned away because they're going to bring down success rates. In NAPRO technology, we work with every couple of any age. We work naturally to help restore ovarian function, which is so important. So things like low ovarian reserve and those types of things. We apply the reproductive endocrinology literature to what we're doing in a natural context. So couples can achieve on their own with all the latest and greatest technology and medical treatments. The missing link, an adequate diagnosis is not made. No adequate diagnosis results in no appropriate therapy. There's a lack of focus on human fertility and an apparent lack of concern for the healthcare of women with these issues. I love this. This is from Donum Vitae. A true and proper right to a child would be contrary to the child's dignity and nature. The child is not an object to which one has a right, nor can he be considered an object of ownership. Rather, a child is a gift, the supreme gift, and a living testimony of the mutual giving of his or her parents. And lastly, I think we forget this. Marriage does not confer on spouses the right to have a child. It does allow spouses the ability to perform the act, to co-create with God, but that's not a guarantee. It doesn't confer a right. The church's response, treatment strategies, we talked a lot about these. But I like to show this. We have couples chart their cycles. There's so much that can be learned from that. I tell patients all the time, let's stop flying blind. I had a patient who went through 5 IVF cycles. And I said, I don't know what's going on. She said, what's the matter? This was the first visit. I said, well, I don't really know, but why don't we stop flying blind? Why don't we look at what's going on? And the day they come back with their chart, things jump off the page, what you can see. It's really amazing. And as doctors, we can start to point that out to couples. And I think that's where true healing begins, whether a child is the end result or not. It's not a right. Naprotechnology doesn't mean you're going to get pregnant. Either does IVF. But there's a real healing for couples when they know what's going on and they don't have the diagnosis of undiagnosed infertility. So they can go to sleep at night together as a couple and say, we know what we're working on. And NAPRO promotes adoption, which is so important. Believe it or not, we're called to adopt children. And we've kind of lost that. And it's a beautiful gift to be adoptive parents. And we support that with our couples and encourage that. These are some infertility charts. I'm not going to go through all these. If I had time, I would. This is summarizing a lot of the research done out of the Institute in terms of looking at hormones related to infertility couples, cervical mucus related infertility couples, and so on and so forth. Just a couple final points and then I'll wrap up. One area that we've kind of jumped into in naprotechnology is surgery. And so gynecology in a way has lost the ability to really treat infertility, endometriosis, some of the big issues facing couples. And out of that has stemmed a restorative reproductive surgical program. And fellows in naprotechnology are trained to be experts in reproductive surgery. Oftentimes, infertility experts will remove a fallopian tube if it's diseased or remove an ovary if it's diseased in anticipation of higher IVF rates. We approach it from a reconstructive restorative perspective, and we're developing these programs all over the country. And at Houston and Methodist, we have our robotic reproductive surgery program, which we're very proud of, and assisting couples in a reproductive fertility-oriented treatment to their gynecologic issues. That's part of the fellowship program, and it really requires an attention to detail, research, and really trailblazing in areas, surgical treatment areas. The church's response has resulted in cooperative infertility treatments that work to correct the underlying dysfunction, resulting in lasting infertility support. When couples come in for infertility on their first visit with me, I tell them, I want this relationship, I like you, but I want this to be a short relationship. Meaning I want to find out what's going on and treat it so you don't need to come back again. If you rely on IVF, you have to go back. Nothing is ever treated. There is no treatment. Pregnancy occurs, a baby occurs, but you're still infertile. With NAPRO, true treatment results in lasting treatment. So the doctor's office becomes a distant memory for these couples. It's so fun when you see them on baby 3 and 4 walking through, and I haven't seen you in years. Well, I haven't needed you. I'm like, that's great. That's fantastic. Last little bit here. What's kind of spanned out of all of this is we have a group of fellows across the country now who are trained in naprotechnology, create and model all these applications. And I know the Institute is so proud of all these physicians that are doing wonderful things. You've heard from some today. And in 2017, we decided we needed a new organization of gynecologists because we really aren't gynecologists in a way. We're something totally different in the way we treat things, in a way true gynecology. And so we developed the Society of Procreative Surgeons, St. John Paul the Great Society in 2017, to coordinate efforts in terms of advancing research and fostering teaching in this area at the physician level. Because I remember sitting at the dinner table, I don't remember what year it was, and my dad sitting there saying, I cannot get a doctor to come help me. And Dr. Young talked about this pamphlet he received. One of my first jobs at the Institute was licking envelopes and sending them out with my brothers. And they were requests to doctors around the country to please come and help. But nobody would come, and it wasn't until the first fellows really started coming, Dr. Stagg, Dr. Dixon, and so on and so forth. But it was so incredibly hard to find anybody to get into this area. And so it's amazing to see the Holy Spirit working with all the people here today and the reach, because it is so needed. And that it's developed now into this group. This is our mission statement as doctors working in this area. I'll let you read it, but I think it's very powerful. And it stems from working on true treatment in women's health that stems from the teachings of the church. The wisdom in the church, Humanae Vitae, has led to wisdom in women's health. Much work is still needed, but those who follow the Great Commission, the doctors, the practitioners, the healthcare providers, are going to do wonderful things continuing to advance this cause. And it truly has, as the church, the lone standout in this area, not bucking to the status quo of just drinking in the contraceptive idea, but staying with women's health has resulted in a complete change in women's health care that allows for true healing for so many. Thank you so much.